Good morning. I'd like to thank the organizers of the All India Ophthalmological Society for allowing me to speak today on imaging differences in plaque conditions. I have no disclosures to make. I will try to display imaging features of 5 different plaque diseases as listed here. This is a bilateral condition with creamy yellow lesions that come on acutely with significant loss of vision in both eyes. The fluorescein angiogram shows hypofluorescence in the early phase. The ICG is always hypofluorescent, so right eye. And here's a mid phase with the fluorescein angiogram that begins to show some hyperfluorescence of the lesions, and the ICG remains dark. However, in the late phases, we have uniform staining of the lesions on fluorescein angiogram. There are a few areas of hyper staining in this eye, and so also in the fellow eye, which is probably likely from small pigment epithelial detachments overlying these plaque lesions. The ICG remains dark in both early and late frames in this condition, and all of us are quite familiar with this disease that was initially described in 1968 by J. Donald M. Gass. On OCG features, you can note that not only is the pigment epithelium involved, but the choriocapillaries, the underlying superficial choroid, and the overlying photoreceptors, both the outer segment and the inner segments are affected, along with the outer nuclear layer. You can see opacification of the outer nuclear layer that is more clearly displayed in this image. Autofluorescence is extremely interesting in this condition, which shows central hypoautofluorescence surrounded by a rim of hyperautofluorescence, and we can see how this can be explained by looking at the OCT, where the opacification of the outer nuclear layer seems to block the autofluorescence imaging, and hence you have the dark center. When APMPP resolves, the lesions get better. Most of the pigment epithelial changes improve, with some hyperreflective lesions left alone, and the outer nuclear layer opacification resolves. There's patchy loss of photoreceptors in the choriocapillaries, and choroid return to normal. Unlike APMPP, relentless placoid is characterized by multiple crops of lesions that come on early on and continue to progress in spite of treatment or the natural resolution of the initial lesions. Here you can see this patient with bilateral multifocal placoid lesions. The fluorescein angiogram is quite typical of what one sees in APMPP, with initial hypofluorescence and late hyperfluorescence. And the OCT is quite similar to what we saw in the previous example with APMPP, with involvement of the outer nuclear layer in addition to the pigment epithelium and the choriocapillaries. Unlike APMPP, this condition needs treatment, usually with steroids, and resolves, but has new crops that come on, as you can see in this example. These images are courtesy Dr. Lee Jampol, and you can see new lesions in the fellow eye. And eventually, when you treat them with steroids and possibly sometimes immunosuppressives based on the severity of the recurrences, one shows resolution of most of the changes. There's patchy loss of photoreceptors and pigment epithelium in this condition, likely a little bit more intense than what we saw with APMPP. The autofluorescence is interesting in the sense that in the previous example, we saw hypoautofluorescence in the center, whereas here we see sort of even hyperautofluorescence of the active lesions, and late lesions show hypoautofluorescence. And autofluorescence imaging can be used to monitor the response to treatment and resolution of the lesions, and eventually the subtotal recovery of the outer retina. Unlike the previous 2 examples, this is a patient with acute TB serpiginoid that all of you are much more familiar with than I am. Patient was positive with quantiferon gold. He has both active and inactive lesions. So lesions in the macula are active. However, they do not look as creamy as the ones you saw with APMPP. The fluorescein angiogram is quite similar to AMP, with early hypofluorescence and late hyperfluorescence. The ICG is also similar to the features in APMPP, with hypofluorescence of the ICG both in the late and early frames. OCT is somewhat different in the slightly subacute lesions. You can see that the changes are more in the choroid and the choriocapillaries. The ellipsoid lines already been affected, but you do not see the opacification of the outer nuclear layer like we saw in the previous example. Some patients with TB serpiginoid can show more changes in the choroid rather than in the pigment epithelium or the photoreceptors, with diffuse thickening of the choroid. And here there's a nodule in the choroid. all of these are various features in different patients with TB serpiginous, and after treatment there is loss of outer retina with photoreceptors and outer nuclear layer loss and dipping in of the outer plexiform layer and the other superficial structures in the retina. Autofluorescence is somewhat different from patients with AP and PP, where you see hyperfluorescence of the active lesions and hypofluorescence of the inactive old scars. And these patients show uniform hyperfluorescence similar to what we saw with relentless placard, unlike the autofluorescence imaging in AP and PP, where you have the central blocked fluorescence from the outer nuclear layer opacification. However, some patients with TB serpiginous can have features resembling AP and PP, like you see in this example. He's an Indian patient I saw in San Francisco who had old inactive scars and now came in with acute lesions with involvement of the central macula. You can see the placoid lesions out in the just above the fovea, in the fovea, and fluorescein angiogram shows hypofluorescence and late hyperfluorescence. The OCT is quite similar to patients with AP and PP, especially closer to the fovea, with opacification of the outer nuclear layer and involvement of the ellipsoid line in addition to the choriocapillaries and the choroid. Again, you can see another example where the outer nuclear layer is somewhat opacified, probably not as intensely as we saw in the previous example, and this may be partly because this is not right in the center of the fovea, where the layer is much thicker than outside the fovea. Autofluorescence shows again something similar to what we saw with AP and PP, with hypoautofluorescence at the center and a rim of hyperautofluorescence, quite similar to the AMP example. So in summary, TB serpiginoid can affect the structures to variable extent, and you can have a slightly different appearance in the autofluorescence and OCT imaging based on the intensity of the structures that are involved, which includes the outer nuclear layer, the photoreceptors, ellipsoid line, the RPE, the choriocapillaries, and the choroid. Here's a placard syphilis with very ill-defined borders. As you can see, it's bilateral, indistinct margins. The fluorescein angiogram shows sort of this ground glass hyperfluorescence that's not as intense as we saw in the previous examples. In addition, most patients with syphilis can have some vascular staining, which is a good feature to look for to establish the diagnosis. Autofluorescence imaging and syphilis looks to show patchy, ill-defined hyperautofluorescence, unlike the autofluorescence features that we saw in the previous two examples. This tells us that the pigment epithelium is sort of irregularly involved and shows hyperautofluorescence. The very important feature to confirm the diagnosis of syphilis is to look at the OCT, which shows diffuse loss of the ellipsoid line and ground glass appearance in the choriocapillaries. That you can see in this example, the pigment epithelium shows this lumpy, bumpy appearance. And if you have this with ellipsoid, diffuse loss of the ellipsoid, one should think about placard syphilis. The important thing to know is that these things can resolve and improve, and the visual acuity can come back to near normal if you make an early diagnosis and not make the misdiagnosis and start the patient on steroids. This patient received penicillin, and the photoreceptor ellipsoid line begins to return, and 5 months later it's completely intact with visual acuity recovery to 20/20 in both eyes. Here's another example where the patient has acute lesions and shows recovery of the photoreceptors. Occasionally, some of these patients can have these superficial retinal infiltrates that are seen especially in men having sex with men, where the lesions are in the inner retina. Unlike the previous examples, persistent placard maculopathy was first described in 2005 in 6 patients by Larry Nuzzi, Lee Jampol, and colleagues, and they saw that many of the patients are recurrent of multiple CNVMs and most lost vision. There was significant macular outer retinal atrophy or disciform scar, which caused significant visual loss in both eyes in most of these patients. However, from the time of the initial description, the spectrum has evolved. We now know that not all patients develop CNVM, and some can recover good vision if you catch them early enough and they do not have a very severe disease. Many of them develop progressive atrophy and disciform scarring. The role of anti-inflammatory and immunosuppressants are not clear. Here's a patient who had bilateral lesions with creamy lesions, and you can see the evidence of CNVM by subretinal hemorrhage in the right eye. The left eye had no hemorrhage. And fluorescein angiogram shows multiple little pinpoint hyperfluorescent spots. Many of them are probably nascent CNVMs. And here you can see a clear-cut CNVM in the right eye that stains on the angiogram. ICG remains dark both early and late. This patient had reasonably good vision in both eyes due to the sparing of the central fovea. On the OCT, you can see evidence of a CNVM with this hyperreflective material that is subretinal. In addition, there's a ground glass appearance of the choriocapillaries, and the pigment epithelium is somewhat hyperreflective. The same in the fellow eye. The fellow eye luckily had good vision and had no evidence of a CNVM that one could pick up on OCT or on the angiogram. You can see subretinal fluid from the CNVM in the right eye here, and CNVM could be confirmed on OCTA. Autofluorescence imaging shows hypoautofluorescence of most of the lesions unless there's some fluid from the CNVM, which can be hyperautofluorescent. This patient was treated with both anti-VEGF injections and steroids, followed by immunosuppressives. The CNVM regressed and the vision came back to 20/20, and he has remained pretty stable for quite some years following the initial treatment. However, unlike the previous example, this patient with persistent placard maculopathy has bilateral lesions with bilateral CNVM as evidenced by subretinal hemorrhages, and he can be seen on OCT with subretinal fluid, irregularity of the pigment epithelium, infiltration of the choriocapillaries, and the superficial choroid. This patient, unfortunately, in spite of steroids, immunosuppressives, and persistent anti-VEGF injections, developed recurrent and actively progressive CNVM, and eventually was left with scars and poor vision. So in summary, persistent placard maculopathy affects the choriocapillaries and the choroid. CNVM is seen often. The secondary photoreceptor changes and atrophy in some eyes with severe disease. In summary, we looked at specific differences in imaging features of various placard diseases. Some of them have an overlap between them. It's likely the pathology is variable. However, there's some similarity in the structures being involved. Prognosis is varied, and the imaging features helps in making the diagnosis. Thank you for your time.
Thank you so much.